Reflux is a very serious problem for patients, but for physicians treating patients in the office, it's certainly something that we see, we're concerned about, and it can be very frustrating to deal with. Tonight we're going to talk about reflux and a whole series of issues which I think are important to talk about related to it. Our guest is Dr. Jamie Koufman. Dr. Koufman is director of the Voice Institute of New York, professor of Otolaryngology at Mount Sinai, and he's in what is a relatively new field and a leader in that field of respiratory reflux therapy and dealing with that. And let me first talk to you about the definition as you have it of reflux and what you think the causes are as we see it.
Well, first of all, reflux just means backflow. And fluere, Latin words, backflow. And it's gastric contents backflowing into the esophagus. And that's pretty much what the gastroenterologists have told us, that reflux is heartburn and indigestion, and it's esophageal disease. In 1981, I first saw a patient that had huge granulomas and airway obstruction and recognized it to be reflux-related. The patient never had heartburn. As of the most recent data we've looked at 200 consecutive patients with reflux who have come to see us. And a really staggering new bit of information is that heartburn was the chief complaint of only 10%. So that means people have got hoarseness, chronic cough, postnasal drip, sensation of a lump in the throat, cough, asthma-like symptoms, allergy-like symptoms, and so on. So there are indeed a host of respiratory diseases that can be caused by respiratory reflux, and it can be misdiagnosed easily.
And I'm sure a lot of us do miss it. I mean, I don't think many of us would miss the classic symptoms when somebody comes in and says they have heartburn and those things. But clearly when there are some of these other signs, especially with the way practices are these days, we're doing so much in such a short period of time. Sometimes we may overlook it or not even ask those questions if the patients don't bring it up. Now, you're in a position where, as a specialist, you probably see the toughest cases as well. So if you were guiding us in practice, what are the things we should be looking for and we should be asking our patients about, in a relatively short amount of time, but to at least target into that aspect?
Well, first of all, people with respiratory reflux often have many symptoms. So they have chronic throat clearing, they have postnasal drip, they have hoarseness, particularly in the morning after they've been out eating and drinking late. And so one of the questions that really ought to be asked is, what time do you eat dinner? Is it the biggest meal of the day? Do you drink alcohol every night? What do you drink in terms of when you go to get yourself something to drink other than water or a cup of coffee? Soft drinks, soda pop are also big risk factors for reflux. So late night eating is probably the number one reason why people get silent reflux. They don't have heartburn, they don't have indigestion. They had a big meal. They basically went to the trough from the time they got home late to the time they went to bed. They fell asleep on the sofa watching the news or whatever, and then they reflux all night. And we don't call them mucous membranes for nothing. So when inflamed, the mucous membranes put out more mucus. So that the question of risk factors for reflux, particularly for silent reflux, are probably more than anything else, not so much what you eat, but when you eat it. So asking patients who have this constellation of symptoms, what time do you eat dinner and is your big meal of the day, it seems to me is the number one question.
And that is really a great question because I know most of our lives, at least there's 1, 2, maybe more nights a week, we're coming home late and trying to do that, trying to get it all together maybe at 8 p.m. or something, whether it's a bad commute or just a long day at work.
Well, it's a problem, and it really has become sort of the American way. People work later, they go to the gym and they work out afterwards, but I don't think people in general and physicians in particular recognize what a big risk factor it is for reflux disease. And by the way, I would like to talk a little bit about asthma. I found it interesting that most physicians, many physicians, don't ask patients, when you have trouble breathing during an asthma attack, you have more trouble getting air in or out. Trouble breathing in is never asthma. Prolonged respiratory phase is asthma. You can have reactive airway disease, but if there's trouble getting air in, then it's usually due to reflux disease. And reflux, there are receptors in the larynx. Those receptors get triggered, believe it or not, by acid and acid alone, and causes closing down of the upper airway. And so people who have inspiratory stridor should not be mistaken for patients who have asthma. And in my practice, more than half of patients who have asthma actually don't have it. And so the other key about that is if your patient's not getting well on asthma treatment, then you may want to go back and revisit this question of respiratory reflux.
If you're just tuning in, you're listening to Primary Care Today on ReachMD. I'm your host, Dr. Brian McDonough. I'm speaking with Dr. Jamie Koufman. We're talking about reflux and talking about some of the things we might be asking about in our practices. But beyond that now, what is standard therapy? Are there things that are new in therapy, things that maybe we haven't thought about as well?
Well, Brian, I think the most important thing to say is that the proton pump inhibitor ship has sailed. The idea that people just have a chronic disease and they're going to stay on a PPI, and you're going to take care of them that way. We know now that long-term use of PPIs is associated with an increased, not decreased, increased risk of developing esophageal cancer. Almost weekly there are new reports linking PPIs with heart problems, with kidney problems, with eye problems. And so the idea that acid suppression alone is the way to treat reflux, I think that's no longer the case. The kinds of things that we do, and that I do in a practice, and in practice I have a PA, I have a staff that does essentially nutritional counseling for our people almost on a day-to-day basis. I mean, we do a lot of email with a lot of our patients. We're looking to make not only reflux go away, and it can, and it will, but we're also looking at what we think is a good longevity diet. So we start out with a 2-week detox. The 2-week detox is strict, and after the 2-week detox, we start adding back foods that are reasonable without going straight to, pepperoni pizza and 2 pitchers of beer on a Saturday night. And we find that people are compliant and they're interested and they lose weight and their diabetes gets better and a lot of other things. I mean, if you really think about it, I don't know how old you are, but I'm 68. In my lifetime, obesity, diabetes, reflux, snoring, sleep apnea, asthma, these are all linked, and they're all linked to diet and lifestyle. So we're actually thinking about these for our patients, and it's really I think, the future.
Well, I think when you talk about it, you make a lot of common sense with a lot of the diet and lifestyle issues, and I know you have tips for quitting or reducing sugar, which you believe also are perhaps contributing to the whole problem with reflux as well.
Well, if I were talking to a patient and they said, what are the top 4 things to do, I'd say close the kitchen at 8. That's number one. If you can close the kitchen at 8, you're going to get... By the way, I had a patient whose child had asthma, and I said, do me a favor and just stop giving bedtime snacks to your child. And the 7-year-old child's asthma went away. So closing the kitchen at 8 is number one, getting rid of soft drinks. And by the way, everything has acid in a bottle or can, so even energy drinks, sports drinks, fruit juices, they're all loaded with acid and a bunch of stuff. Never fall asleep drunk. If someone falls asleep with a big buzz or drunk, they're going to be refluxing all night. And then really, it's sort of intuitive. Eat lean, clean, green, and alkaline. It's alkaline, but alkaline.
It doesn't rhyme if you say alkaline.
Alkaline water, it turns out, is really, really good for reflux.
I mean, and these are simple things you can follow. It's not that dramatic. I think one of the issues we always have in healthcare is we tend to make things so much more complex than it has to be. And I think sometimes people are turned off by that, or, it's just difficult. They might feel motivated when they leave the office, but, a couple days later, they more or less forget what you even talked about. But
My
if it's something...
experience is if you tell people that they can make a big difference, I have 2 books. Dropping Acid is sort of the starter book for refluxers, and the new book, Dr. Koufman's Dropping Acid Diet, is essentially a longevity diet or the advanced course. There's a lot of discussion about sugar. There's 80% of the products in a supermarket have sugar added. You can't find a breakfast cereal that doesn't have sugar. So that the same snack foods that are reflux causing are also loaded with sugar. So, when you talk about eliminating sugar, first thing you got to do is get rid of the obvious things, anything that has high fructose corn syrup in it. Get rid of the cupcakes and the cookies and the ice cream in the freezer. Get candy out of the house. Have these things as a treat when you go out. Have a dessert, but don't be eating them all night, every night. Eliminate soft drinks. Bread is a big issue. I'm sure you've read Wheat Belly. This question about the glycemic index of bread being higher than that of cane sugar. Excess sugar turns into fat. And bread is the American staple, right? Bread is breakfast, lunch, dinner, snacks. And then breakfast cereals. And so, I actually have my patients reading labels. For example, I'm a big fan of chicken stock because I don't want to be boiling chickens all the time to have stock to cook with. And so turns out there are some brands, but not very many, that don't add sugar. So once you find one that you like, you say, okay, this is a good brand. This one has not a bunch of chemicals and no added sugar. And you start substituting things. And the fruit that people want to have sugar, bananas, red apples, pears, figs, and dates have the most sugar, and they can be considered desserts for people, particularly the dates. They're high sugar bombs. And so, there are ways of doing it. And for actual sugar alternatives, natural honey, molasses, and stevia. Stevia has not had a lot of discussion yet, but, it has no calories, and it's probably going to turn out to be quite a good sugar substitute.
I want to switch gears just a little bit. They were all great points, and talk about what you do as far as being a respiratory reflux specialist. Tell me about that.
Well, I see people who come to me with breathing problems, and they can have, if you have patients that have COPD and they're non-smokers, we don't really have that many causes of lung disease. If people don't smoke, they don't work in sooty factories anymore. So people who have, if people wake up in the middle of the night coughing, people wake up in the morning coughing, a wet cough usually means reflux. A chronic wet cough usually means reflux. That dry cough, maybe it's something else. So what I'm saying is that a lot of patients who have lung disease have reflux, and it's not diagnosed because the patient goes to the gastroenterologist. The gastroenterologist does an endoscopy. The esophagus isn't so bad. So, but it doesn't mean they don't have respiratory reflux. We've been doing reflux testing where we put a very high-quality pH sensing device in both the esophagus and the pharynx now since 1987. And what we've done is show that these people actually have reflux disease, even if they don't have heartburn and even if they don't have esophagitis. So I think the most important feature for the clinician is to recognize that respiratory reflux is a big deal, that it's hard to diagnose, and if you don't think of it, you'll never diagnose it.
Do you think word's getting out there? Obviously, you're doing your best. You've got books, and you're doing talk shows, and you're speaking to physicians, but do you think word's getting out about this?
I do. I was listening to something on the Internet. It had nothing to do with me, and it was a gastroenterologist talking on a program, and the word reflux that involves the respiratory system must be considered. I spoke at the chronic cough conference this year, and the pulmonologists have, I understand, I've not seen it, a new clinical guideline coming out for cough that says if the patient doesn't have an identified cause, think of respiratory reflux, and even silent reflux, meaning no heartburn, no indigestion. So, but even if the word's not yet general information, a show like yours, this is important for people to think about, and it's not always easy to diagnose, and it's not always easy to treat. But it must be it must now be in the dialogue, in the conversation.
You've been listening to Dr. Jamie Koufman. He's the director of the Voice Institute of New York. He's a professor of otolaryngology at Mount Sinai and a respiratory reflux specialist. I'm afraid, Dr. Koufman, we run out of time, but I want to thank you for joining us and sharing your insights on primary care today.
Thank you very much.
This is Dr. Brian McDonough. If you missed any of this discussion, please visit reachmd.com/primary care today. You can download the podcast, learn more on the series. Thank you very much for listening.